Hello dear students, today we have our fourth lecture on course on 5, Transverse Direction Anomalies, Clinical, Diagnostic and Therapeutic Methods. Transverse discrepancies warrant special consideration in orthodontic diagnosis and treatment planning. Transverse relationships include dental midline discrepancies with the face, posterior crossbites, and asymmetry in the upper and lower arches. The presence or absence of a functional shift on closure is important information for all patients who have anterior and posterior crossbites. Asymmetry in craniofacial morphology can be recognized as differences in the size or relationship of the right and left sides. This may be the result of imbalance in the individual position and form of teeth, variation in the position of bones of the craniofacial complex, and it may also be limited to the overlying soft tissues. It is recognized that the human face displays bilateral symmetry exhibiting mirror image characteristics between right and left halves. It is perfect bilateral dentofacial or craniofacial symmetry, predominantly a theoretical concept, and seldom exists due to the large biological variation, either inherent in the developmental process or caused by environmental disturbances. Such symmetry is rarely encountered. Certain degree of asymmetry goes unnoticed and is often considered normal. However, the point at which this mild transverse discrepancy becomes abnormal cannot be easily defined, as it is influenced by the clinician's understanding of asymmetry and the patient's perception of imbalance. As the patients view themselves from the frontal perspective, enabling them to compare right and left sides of the face, contemporary orthodontic diagnosis and treatment planning should incorporate identification of transverse problems and achievement of symmetric results with appropriate mechanics. Transverse relationship and symmetry. The transverse proportion of the face should divide approximately into fifth. No face is truly symmetrical, as we said. However, any significant facial asymmetry and the level at which it occurs should be noted. This can be done by assessing the patient from the front and also from behind and above, looking down the face. The relative position of each dental midline to the relevant dental base should be recorded. Here you can see transverse facial proportions, which divided into fifth. And of course we have to see facial asymmetry viewed from above and behind. Then facial asymmetries, depending upon the structures involved, can be primarily dental, skeletal, functional in origin, or may even have combination of these factors present. It is equally important to determine the relationship of the transverse discrepancy with the sagittal and vertical problems, which often have a significant impact on designing a treatment strategy. The management of transverse discrepancies has been universally recognized as one of the most challenging aspects of orthodontic therapy. And comprehensively, we now have to deal with the development, differential diagnosis, and treatment of such problems. And if you consider the classification based on the structure involved, dentofacial asymmetric relationships can result mainly from genetic alteration in the mechanisms that is responsible to establish symmetry and various environmental factors producing differences in right and left halves. Some of this asymmetry are observed in individuals with craniofacial syndromes. Dental crossbites. Crossbite is confined to the dentition, mainly lingual tipping of upper teeth, or less frequently buccal tipping of lower teeth. Skeletal crossbites, crossbite involving the skeletal structures, mainly maxillary constriction, and functional crossbite, occlusal interference will lead to mandibular shift on closure, resulting in unilateral posterior crossbite. Posterior crossbite itself should be posterior, is defined as a relationship in which one or more deciduous primary or permanent posterior teeth occlude in an abnormal buccal-lingual relation with their antagonists. They may be unilateral or bilateral, maxillary or mandibular, buccal or lingual, dental or skeletal, and may be accompanied by lateral functional shift of mandible, especially in unilateral crossbites. If you consider the classification based on the number of teeth involved, then we can consider the single tooth posterior crossbite and segmental posterior crossbite, a crossbite that involves a group of posterior teeth. The greater the number of teeth in crossbite, the greater is the skeletal component of the etiology. Posterior crossbites have 6 possible explanations, and it can be these transfer discrepancies mainly caused by local factors like premature loss of deciduous teeth, congenitally missing single tooth or group of teeth, and certain habits like thumb sucking or tongue thrusting. And these dental asymmetries essentially involve midline deviation, asymmetric posterior tooth position, asymmetric arch forms, and diverging occlusal planes. So, the 6 possible explanations of posterior crossbites are following. 1. The upper arch is too narrow. The lower arch is too wide. A lateral functional shift occurs during closure of the mandible. 1 or more teeth are displaced toward the plate in the maxillary alveolar ridge. 1 or more teeth are displaced towards the buccal side of the mandibular alveolar ridge. Combination of the above 5 explanations. Consider the classification based on the position of upper molars. You can say that they are divided in 2 parts. Palatal posterior crossbite is the most common and refers to a condition where buccal cusp of one or more maxillary posterior teeth occlude lingual to buccal cusp of mandibular teeth. And buccal crossbite or scissor bite. The palatal cusp of maxillary teeth occlude buccal to mandibular teeth. This type is less common and associated with underlying skeletal discrepancy, often class 2 malocclusion. According to the presence of crossbite on single or both sides of dental arch, there are unilateral crossbite, like here in this photo, which associated with mandibular shift on closure or less frequently may result from true arch asymmetry. And this is unilateral crossbite. And bilateral crossbite are more likely to be associated with skeletal discrepancy in the transverse or anterior-posterior plane, for instance, during narrow upper arch. This is unilateral and bilateral crossbites. As you say before, dentofacial asymmetric relationships can result whether from has genetic origin or various environmental factors. For instance, in the external factors, they can be prolonged thumb sucking habit. Retention of primary teeth also can cause deflection of erupting permanent successor leading to a crossbite. Premature loss of primary molars is also lead to loss of space and palatal eruption of premolar teeth. A mismatch in the relative width of arches, anterior-posterior skeletal problem, severe maxillary retrognatism or mandibular prognatism also can result in posterior crossbite even with normal transfer maxillary width, and true skeletal asymmetry of maxilla or mandible. Hemifacial microsomia, clefting syndromes, and craniosynostosis are some of examples characterized by significant facial asymmetries. Some clefts of the lip and cleft palate are genetically influenced, leading to significant facial abnormality associated with collapse of the maxillary dental arch. In certain situations, also some of the facial imbalance is found primarily in the soft tissue. Skeletal contributions can be significant. In addition to asymmetric mandibular positioning, morphological variation between the right and left sides of the mandible, like differences in the length of the body of the mandible or height of the developing ramus, can lead to asymmetries. And molding of facial bones due to intrauterine pressure during pregnancy and significant pressure in the birth canal during parturition can result in facial asymmetry. These changes are usually considered as transient, which undergo rapid restoration of the normal skull relationship within a few weeks to several months. Trauma or infection within the temporomandibular joint also can cause ankylosis of the condyle to the temporal bone. The loss of muscle function and tone as a result of damage to nerve may indirectly lead to asymmetry. Various pathological conditions, not necessarily congenital in nature, cause craniofacial asymmetries. Osteochondroma of the mandibular condyle leads to facial asymmetry, mandibular deviation, and open bite on the involved side. And if you consider the dental causes, you can say about primary molars, which can ankylose, and the adjacent teeth continue to erupt as a part of dental-alveolar development and appear to tip over the crown of the ankylosed tooth. These result in a loss of space and asymmetric axial inclinations of the adjacent teeth and subsequent asymmetric molar occlusion. And as you say before, congenitally missing teeth, supernumerary teeth, or ectopic eruptions are common causes for developing occlusal asymmetries. Asymmetries in arch form, which can also be characterized by midline discrepancies, are often produced by habits. Transverse discrepancies are also caused by functional mandibular shifts due to centric prematurities leading to lateral mandibular displacements in habitual occlusion. Temporomandibular joint disorders like articular disc dislocation or fossa changes are often associated with asymmetries involving off-centered midline. Contemporary orthodontic diagnostic process must involve an assessment of problems in the transverse dimension, minor asymmetries that are often neglected, or underlying asymmetries that are masked by dental compensation, if undiagnosed at the beginning of treatment, usually become apparent as treatment progresses, especially during the finishing stage. This prolongs the treatment duration, causes certain alteration or changes in treatment direction, or it will ultimately leave the patient with a compromised result. To avoid this untoward situation, every clinician should make a conscious effort to assess dentofacial abnormalities in the transverse plane. And as we highlighted before, types of transverse discrepancies include dental asymmetries in one or both arches, skeletal asymmetries involving maxilla or mandible, functional mandibular shifts causing asymmetric maxillomandibular relationships, and muscular asymmetries. Midline deviation. It's quite often most individuals presenting for orthodontic treatment do not exhibit coincident maxillary or mandibular dental midlines with each other or with the facial midline. This may be because of displacement or distortion of the maxillary or mandibular dental arches, tooth rotations, tooth size discrepancies, asymmetric crowding or spacing. Midline deviation certainly warrants special consideration in the orthodontic diagnosis and treatment planning. However, aesthetic acceptability of dental midline discrepancies depends on individual factors, including the transverse discrepancies associated with other facial midline structures. It has been found that overjet and dental crowding or spacing were considered to be more significant factors than midline deviation in determining self-satisfaction with dental appearance. In contrast, another study found that symmetry was one of the most important factors in defining an attractive smile. Generally, a dental midline deviation of 2 millimeters or more is considered to be easily detectable by most individuals and therefore warrants its consideration in treatment planning process. Individuals with midline discrepancies present with a variety of clinical situations where maxillary midline is coincident with facial midline and the mandibular dental midline is shifted either to the left or right side. Mandibular midline is normally positioned, but the maxillary midline is deviated to the left or right sides, or it could be the combination of both. Here we see maxillary skeletal constriction and V-shaped arch form, which also lead to the bilateral crossbite, posterior crossbite, and asymmetric mandibular arch form due to the mesiolingual drifting of the mandibular right buccal segment. Skeletal transverse discrepancies. Transverse skeletal discrepancies may involve either the maxilla or the mandible or a combination of both. The maxillary problems in a transverse dimension usually result from a symmetric or an asymmetric constriction of the basal arch with or without posterior crossbite, depending upon the severity of the condition. The maxilla can undergo some rotational changes relative to the cranial base, producing an asymmetric occlusal relationship. Most people have some facial asymmetry and asymmetric development of the jaws, though rare, does produce transverse problems. Severe skeletal problems in a transverse dimension are often produced by some congenital anomalies like facial clefts and trauma or infection. Patients with cleft lip and palate pose a unique problem requiring extensive and prolonged orthodontic care. Individuals with a lateral cleft typically exhibits lingually collapsed maxillary posterior segments and labially displaced premaxillary segment, leading to extreme distortion of the maxilla. The surgical repair of the lip and palate carried out an early stage for aesthetic and functional reasons often results into some degree of lateral constriction of the palate and constriction across anterior segment of maxillary arch in the early and late mixed dentition. Transverse mandibular problems result from both asymmetric positioning and asymmetric morphology of the mandible. An abnormal growth of the cranial base may lead to asymmetries in the position of the glenoid fossa and subsequent rotation of the mandible relative to the maxilla. Mandibular asymmetries significantly contribute to facial asymmetries, and it is important for the clinician to identify whether a resultant problem is due a congenital anomaly or trauma. Muscular asymmetries. Any deviation from normal muscle function plays an important role in the development of skeletal and dental transfer discrepancies. Muscular asymmetry, as commonly observed in hemifacial atrophy or cerebral palsy, is one of the factors responsible for facial disproportion and the midline discrepancies. Sometimes facial transverse problems are confined mainly to the soft tissue due to disproportionate muscle size as seen in masseter muscle hypertrophy. Functional transfer problems. Functional transfer discrepancies are often caused by a deflection of the mandible due to occlusal interferences. During mandibular closure, the abnormal initial tooth contact in centric relation results in subsequent mandibular displacement laterally or anteroposteriorly, leading to asymmetric maxillomandibular relationship. The functional mandibular deviations are caused by a malpose tooth or by a symmetric or an asymmetric constructed maxillary arch. Assessment of transfer problems. The diagnosis of transfer discrepancies should be accomplished by a thorough clinical examination and an analysis of various diagnostic records to determine the extent of involvement of dental, skeletal, soft tissue, and functional components. The goal of these diagnostic procedures is to identify the causative factor and determine the location and extent of the transverse problem. The differential diagnosis of transverse discrepancies is critical to formulate proper treatment plan. So during diagnosis clinical examination, it is important to determine whether a unilateral crossbite is associated with lateral mandibular shift. This is achieved by examining mandibular position in centric relation and centric occlusion. Because one of the challenges in treatment planning and treatment of transverse problem is the proper alignment of maxillary and mandibular dental midlines. Not only should they be coincident with each other, but they must also exhibit a definite relationship with the face. The clinical examination is of vital importance as it enables the clinician to carry out dynamic assessment of these discrepancies. So, to establish different diagnosis of the midline discrepancies, the dental midline should be evaluated in different mandibular position. Then we have we can ask patient to open his mouth and to see how his initial teeth contact in centric relation and in centric occlusion. Functional transfer problems due to occlusal interferences lead to a mandibular functional shift following initial tooth contact. These functional mandibular shifts may accentuate or mask the midline discrepancy depending upon the direction of shift in the same or opposite direction of the dental or skeletal discrepancy. Maxillary and mandibular dental arches should be thoroughly examined for arch symmetry and their coordination and for a more localized factor like malposed or displaced tooth. Clinical assessment of the patient must involve the examination of temporomandibular joint and associated musculature, since certain temporomandibular joint disorders causing interferences in normal mandibular translation result in mandibular deviation. And the facial midline also is an important component of facial aesthetics, and its proper clinical evaluation must become an integral integral part of the clinical examination. A common procedure adopted by most clinicians to evaluate the facial midline is to use a dental instrument, handle, shaft, or a piece of dental floss to connect soft tissue points at nasion, subnasal, and pogonian. For this reason, because it's a little bit difficult to accurately identify these points, for these reasons, the phibtrum is considered to be a reliable midline structure and in most instances can be used as the basis for midline assessment. Another approach is to observe the distance between the canine or first premolar and corner of the mouth. In the presence of midline deviation, the patient will notice a unequal amount of tooth exposure on the right and left side. In clinical examination, the clinician must record the extent to which the maxillary midline is deviated from the facial soft tissue midline, since the orthodontic treatment goal is to position the two midlines and the mandibular midline so they are aligned with each other. Also, of course, radiographic examination is very helpful in determining the asymmetry, the skeletal asymmetry, while clinical examination is an important step in diagnostic procedures for the orthodontist to assess dynamic relationship of orofacial complex. Certain radiograph projections provide valuable information to differentiate between various types of transfer discrepancies. A number of radiographic projections are available for accurate identification of the location and ethiopathology of transverse problems. The lateral cephalometric radiograph provides little useful information on transfer discrepancies. Mostly we use the lateral cephalometric radiographs during anterior-posterior discrepancies, like when we want to determine the class 2 or class 3 malocclusions, especially in the position of mandible or maxillary towards the sagittal, towards the base of the cranium, anterior base of the cranium. However, it is a valuable diagnostic tool to locate and quantify associated vertical and sagittal problems in the craniofacial complex. To a certain extent, this view enables the clinician to assess ramal height, gonial angle, and mandibular length. But due to the inherent characteristic of this projection, like superimposition of the right and left structures and variation in the magnifications as a result of their different distances from the film and X-ray source, its interpretation in diagnosing transverse problems is limited value. The panoramic radiograph is a useful view for an overall examination of the dental and bony structures of the maxilla and mandible. Certain conditions like missing or supernumeraries, impacted teeth, the presence of gross pathology can be assessed. It also provides valuable information on comparison of some structures such as mandibular ramus, condyles, and configuration of inferior border of the mandible on both sides. That's why we mostly, in determination of transfer anomalies, we use posterior-anterior cephalogram. For cephalometric assessments of orthodontic problems, the routinely prescribed radiograph is a lateral cephalogram, but as I said before, but only when a transfer problem or an asymmetry of face is detected, then the clinician asks for frontal radiograph. It is a valuable tool in assessment of the right and left structures of dentofacial complex. Since the structures are located at relatively equal distances from the film and X-ray source, this promotes proper registration and evaluation of the facial and dental midlines and an accurate comparison between the sides to determine the extent of the asymmetry present. The use of anterior-posterior or posterior-anterior cephalogram is fraught with inherent problems: difficulty in reproducing head posture, difficulty in identifying landmark because of superimposed structures or poor radiographic technique, and concern about exposure to radiation. Posterior crossbites, transverse arch expansion, increasing dental arch dimension in both anterior-posterior and transverse planes can create space. Problem with this strategy can arise because the teeth occupy a zone of equilibrium between the soft tissue forces of the tongue on one side and the lips and cheeks on the other. If the teeth are moved excessively in either buccal or labial directions, they will move outside this zone of stability and potentially be subject of unbalanced forces that will tend to return them to their previous position. In particular, there are significant restrictions on how far the position of the teeth can be changed in the lower arch, especially in the intercanine width. This dimension is established early during development of the dentition, and any subsequent expansion is inherently unstable. Expansion of the lower arch to relieve labial segment crowding should be therefore avoided. And I also to memorize that the mandibular asymmetry has been described as primarily of two types: hemimandibular hyperplasia, characterized by three-dimensional enlargement of the mandible, which terminates at the symphysis. There is an increase in height on the affected side, usually accompanied by a marked cant of the occlusal plane. This can be seen by asking the patient to bite onto a wooden tongue spatula. And hemimandibular elongation, characterized by horizontal displacement of the mandible and chin point towards the unaffected side. There is usually a marked central shift and a crossbite on the contralateral side, but no occlusal cant. The displacement of a tooth palatally in the maxilla or buccally in the mandible, as you see here, you see here we see some displacement palatally maxillary tooth and buccally mandibular, may result in a localized crossbite and is usually a reflection of crowding. Also, a removable appliance with a palatal spring can be used to tip this teeth buccally. If space is created, the tooth will usually need to be bodily moved, necessitating of the use of fixed appliances. When there is a transfer discrepancy between the dental arches, a crossbite can affect all the teeth in the quadrant. Posterior crossbite can be, as we say before, unilateral or bilateral, depending upon whether one or two sides of the dental arch are affected. Where the discrepancy is small and mostly dental in origin, a displacement affecting the mandibular dentition can often be elicited on clothing from initial contact in the intercuspal position, ICP, resulting in a unilateral posterior crossbite without displacement. A skeletal asymmetry can produce a unilateral crossbite. However, if the discrepancy is large, a bilateral crossbite may occur. This is commonly found in severe class 3 malocclusion and is both a reflection of the transverse discrepancy and the relative anterior-posterior positioning of the jaws. The greater the skeletal contribution to a crossbite, the more difficult it is to correct. A skeletal crossbite with no associated displacement of the mandible on closing is often best accepted, especially if it is bilateral. Attempting orthodontic correction in these cases may result in the creation of a unilateral crossbite with a displacement, which is occlusally less acceptable. As it is very difficult to construct the mandibular arch, any treatment will usually involve expansion of the mandibular arch. Various techniques can be used to achieve this, but all will produce considerable tipping of the maxillary buccal teeth, with the exception of surgical expansion. On expansion, there will be a relative extrusion of this palatal cusp as the teeth are tipped. This can be a problem in a patient with a reduced overbite, as this will worsen due to the displacement of the mandible downwards and backwards. Removable appliances are effective for the expansion, particularly in the mixed dentition, using a midline expansion screw which the patient activates. Heavy forces and rapid expansion are not indicated in young children, since there is a significant risk of distortion of nose. Palatal expansion can be achieved with slow activation using either of the following appliances: split plate removable appliance with expansion screw. However, it depends on patient compliance and treatment can take long time. Active plate split in midline will expand constricted maxillary arch almost totally by tipping the posterior tooth buccally, not by opening mid-palatal structure. Therefore, this appliance is not indicated for skeletal crossbites or dental expansion for more than 2 millimeters per side. So during when we use removable appliances, we just expand the dental arch by tipping of posterior tooth. Here also we see split acrylic expander, which we use during mixed dentition stage, as you see, and sometimes we put some occlusal bite plane to the acryl split because it can provide more bodily movement of posterior teeth. Fixed palatal expanders, such as quad helix, quad helix can be used for dental expansion, while rapid maxillary expansion, RME or RPE, rapid palatal expander, can produce a significant component of skeletal expansion in growing patients. The quad helix appliance is cemented to bands on the first molars and activated by expanding approximately a molar width. This will produce slow dental expansion, mostly by tipping the teeth buccally. It is therefore contraindicated when skeletal expansion is needed or when the maxillary molars are already tipped buccally, as active arch expansion has a high potential for relapse. The maxillary arch should be overexpanded, so expansion is continued until the palatal cusp of the maxillary molars occlude in the lingual inclines of the buccal cusp of the mandibular molars. If no further treatment is planned, the quad helix should be left in place for a further 3 months as a retainer. Rapid palatal maxillary expansion can produce a significant component of skeletal expansion in growing patient, and RP or RME is undertaken over a period of 2 to 4 weeks, with the patient activating the appliance between 1 and 4 times a day, producing up to 1 millimeter of expansion a day. This generates a large forces that in a child or adolescent will split the maxillary suture, resulting in initially mostly skeletal expansion. This is the stages of preparing a Hyrax expander or RP expander. As you see, firstly we fitted the bands on first molars and first premolars. Then we take impression with alginate. A Hyrax jack screw and wire arms fitted into the plate. Then we solder appliance on the working cast. And here are RME ready in use. So during 2 or 3 weeks, we obtained about 10 millimeters or more of expansion. About 10 millimeters or more of expansion obtained, and the suture opens as if on a hinge superiorly at the base of the nose and opens more anteriorly than posteriorly. The space created is filled initially by tissue fluids and hemorrhage. After 10 days or during 10 days, we can say diastema appears between central incisors as the bones separate. The appliance should be stabilized and left in place for 3-4 months. During this time, new bone fill the space and midline diastema disappear. At the end of retention period, the net result would be equal amount of skeletal and dental expansion. This is lingual. Also, here quad helix, and we said about quad helix before. Sometimes, alternatively, for expansion of arch, we use auxiliary buccal arch. This auxiliary buccal arch, constructed from 0.9 millimeter steel, and it's placed in the molar headgear tubes and expanded the tooth arch. Cross elastics can also be run from the palatal aspects of the maxillary teeth and buccal aspects of mandibular teeth to correct crossbites. As well as a transverse force component, this will also produce a vertical force and as such is contraindicated in patients where extrusion of teeth in the buccal segments should be avoided. If an arch wire with a larger arch form is chosen from the outset of treatment and twinned with a low friction bracket system, significant expansion and change in arch form is possible. However, there is no evidence that this is any more stable than any other method of expansion. Irrespective of what type of expansion is undertaken, relapse potential is high. These can be reduced by establishing good intercuspation of the buccal dentition at the end of the treatment, but a long period of retention will usually be required. And during early mixed dentition, we don't use heavy forces and rapid expansion because they can cause a significant risk of distortion of nose. Palatal expansion can be achieved with slow activation using either of the following appliances, and split plate removable appliance with expansion screw also is very often used during mixed dentition. However, it depends on patient compliance and treatment can take long time. So, when we consider the treatment plan, you can we can take into consideration the skeletal and dental contribution to crossbite, age of the patient, and functional contribution to crossbite. Posterior crossbite should be treated as early as possible, even in the primary dentition. Early correction will eliminate mandibular shift on closure and reduce the possibility of mandibular skeletal asymmetry. And correcting posterior crossbite in the mixed dentition increases arch circumferences and provides more room for permanent teeth to erupt and reduce dental arch distortion. This is myofunctional trainers, which we use during open bite and during crossbite, during early mixed dentition stage. And as you can see here, we can achieve the result in 3 or 4 months. This is also a result which can be get during couple of weeks because of low forces from quad helix. Also, I want to say about lingual posterior crossbites, and it often occurs, particularly when crowding causes a maxillary premolar to be displaced buccally. In a child, a functional appliance can be used to correct this relationship, and by doing so, this may help correct the lingual crossbite. In an adult, fixed appliances can be used with cross elastics and an expanded mandibular arch wire. However, orthodontic expansion of the mandibular arch to any significant extent is problematic. The preferred appliance is adjustable lingual arch that is banded to lingual arches. Also can consider the age of the patient and the severity of pathology. And sometimes for widening of the mandibular arch, if it's too narrow, you can use surgical techniques using destruction osteogenesis, but we will discuss about this in our last lecture. For today, thank you for attention and hope you all be okay. Thank you.